Yes, we.
Okay, so a very good evening, friends. Welcome to the 38th Indian Arthroplasty Association webinar. And this time we have a very practical sort of webinar, mainly focusing on the difficulties that we face in some of the cases that we have, and in particular about obesity and osteoporosis. So, um, without much ado, I welcome all the speakers, and I'm grateful to all the speakers for their participation, and in particular for taking up the challenge, Dr. Ramnik Mahajan. So, without much ado, I hand over the proceedings to Dr. Ramnik.
Yeah. Thank you so much, Dr. Ajit. I welcome everyone to this 38th IAA webinar. So the rules of the house were very simple. We wanted to keep it simple, practical. So we chose the topics wherein either obesity, osteoporosis, or a combined which you can find either with patients like rheumatoids and other patients. All these things are challenges where they put you into a question mark, when to do, what to do. So that is what was the take home with them. Probably at the end, when Rajkumar summarizes, we will have a take home message. But at the end, also, when the speakers were lined up, the message to the speakers was also is try to keep it crisp, practical, as so that after the end of their talk, we actually end up learning something practical. Everybody does total knee every day. The rules of the house are simple. Everyone is allotted 5 minutes, and I would request the speakers to try to limit them in the 5 minutes so that we have some time for discussions. I think Dr. Ajit, you're trying to say something? You're muted. Hello?
Carry on. Just getting to Dr. Samir Ali.
Okay, yeah. So rules were simple, 5 minutes, and probably between me, Dr. Ajit, and we all are friends here. So we all each other so that we try to stick on time and we are able to finish off by 9 o'clock. So without much further, I will ask Dr. Rakesh Rajput to come up and take his talk on medical management of osteoporosis first, or planning to do a total knee followed by medical management of osteoporosis, whatever he says. Over to you, Dr. Rakesh.
Yeah. Am I audible and visible, Ramnik?
Yes, you are.
Okay, so I'll just kickstart. The topic I was actually given was the medical management of osteoporosis. Should be done first or should TKR be done first? I'll just throw a bit light on the others. But first thing first, these are our learning points. And we'll first discuss whether osteoporosis and osteopenia actually are a problem for patients having TKR. Do we agree with that? And if we agree, how big is this problem? What happens when we operate patients with osteoporosis, or what are the likelihood of complications we run into? And the question which really is pertinent is, should we wait and treat osteoporosis before we do a TKR or probably any other joint? And if we have done a patient with osteoporosis or even severe osteopenia, should we treat them afterwards? So that's another point we got to highlight. And after doing all this, does it make any sense, or is it actually beneficial to do this? And if we are going to treat, I'll just go across some few drugs which are available for treating this. So first thing first, what is this prevalence of osteoporosis? So when we are tackling patients with osteoporosis, and this is one patient from Maximilian, they have looked at 109 patients, and they were keeping the osteoporosis at 2.5 minus DEXA, below that or not. And believe it or not, 17% were actually quite severely osteoporotic, and severe osteopenia was also half of them. So you can imagine like 1/3 of them are running into fairly severe osteopenia or osteoporosis as such. And according to their paper, at the last thing was, and they were looking at above 65, by the way, but they realized that after 70, probably everyone should be getting a DEXA scan who are coming for the operation. So that's one question solved. The second question we have is, so what happens when we do patients who've got this high osteoporosis? And if you look at this paper, it's from Baltimore, and you see the bottom author there, Sabyasachi Thakkar. And many of you might not know, he's actually son of Dr. C.J. Thakkar and a very prominent surgeon in Maryland and Baltimore. So according to their paper, if you look at the what happens with patients with osteoporosis. The twofold increased risk of complications, particularly with periprosthetic fractures. And there is also a increased risk of revision from all causes, including aseptic loosening and prosthetic joint infection also. Now, obesity, if you have along with this, will actually complicate matters further. So they hadn't separated completely obesity, but that's one of the conclusions they came, that we should probably look at osteoporosis only and not any other compounding factors to actually have a proper outcome. Now, what happens when you do a TKR? So this was one study which was from Korea, which was looking at TKR patients who were given bisphosphonate and who were not given bisphosphonate. So what happens? And they found that the general BMD actually increases for everybody who undergoes a TKR to some extent. So it is expected, because patients will have lots of exercises going in, they will start becoming more mobile, they'll probably health will increase and fitness will increase. They can do more exercises. So there's a natural increase in BMD for these patients. But if you look at the treatment group, it will have BMD increase both at spine and hips. Whereas if it is just a natural progression, you will increase BMD in spine, but not at hips. So you will still run chances of fracture in your neck femur. Now, what drugs actually make it better? So you just saw one paper where I've discussed bisphosphonates make it better. And traditionally, that was the treatment only available to us. But over the last many years, we've had denosumab, which has come in quite well, both as an independent factor to be treating osteoporosis and also as an ongoing process after you're finished with teriparatide. So if you look at denosumab itself, it has shown that even objectively that the stem migration seems to be much less if you're giving osteoporosis treatment with denosumab. So they were looking especially at component loosening and migration, and they found good long-term benefits also with this. So that's one drug which is useful. Now, we also know that teriparatide has also been used, and similarly, there are other papers which will tell you that teriparatide is also useful. So we now have bisphosphonates, we have denosumab, we have teriparatide. So bisphosphonates were not universally very good for many of these patients. Also, bisphosphonates have got a problem once you start going for long-term treatment, particularly after 4 or 5 years, then you run into the atypical femoral fractures and retarded bone healing. So that's a problem with bisphosphonates, and that's why we need to look at probably alternating with other drugs also. But now we have luckily, and the denosumab and teriparatide were injectables. So there was a long-term research going on whether we can get hold of oral drugs. And we have very recently come across this new drug, which is made up of collagens. And the one we are looking for really is the type 1, 2, and 3 collagen. And what you're looking for in collagen is basically specific collagen peptide. So what's a peptide? And if you have amino acids which have got probably 2 or more in combination, you get a peptide. And when you eat these proteins, they get broken down and you need amino acids from that. So these are all amino acids. We probably have 20, or some people might say 21 amino acids, but about 9 of them are very essential, which means you cannot actually make them in your body. You have to eat from outer sources. And few of them are like lysine, leucine, arginine, and all that. So these are essential amino acids. So this core dense, as we call it, it's one of the nutraceuticals. If you look at the effect it has, the action, it has an action both on osteoclast and it has an action on osteoblast also. So the action on osteoclast is very easy to say, that anti-resorptive action is decreased. On osteoblast, you have 2 types of actions you're looking at. One is that bone mineral deposition, and the other is actually mineralization of the osteoid. So one, you have osteoid formation and then the mineralization of the osteoid. And this nutraceutical seems to be working, or the collagen peptide seems to be working on all of them. Whereas if you look at the others, they will work on some factors and not the others. So all 3, you have only this, and luckily this is available orally. And we now talk about the pillars of bone health, which is calcium, one of these peptides, and vitamin D. So let's look at whether they are useful or not. And this is a study which is about a 12-month study, which is looking at the difference in BMD after giving 1 year of the treatment. And you see the difference in spine and in the femoral neck. There's a 4.2% and 7.7% increase in BMD respectively. So a useful product which has already shown differences in BMD. What about if you look at the long-term benefits of this compared to a placebo? Again, you can see a very good treatment differences between the long-term action of this. So even over a period of time, for a long time, you can treat this with these sort of drugs. The question is, what happens when you add the other 2 pillars, which is the calcium and vitamin D, and you see a very synergistic action, which is very clear from this graph here, that there is a decrease of minus 11.4%. So you really decrease and what are we decreasing? This chemicals which come out into urine. So the C peptides and the N peptides, which is what the biomarkers in your urine are for the breakdown products of your body. So the bone turnover. So this actually shows you that you are now healing bones, and this decrease in C and N peptides in your urine are decreased. So again, a very good marker for immediate action. And if you combine these three, we've seen that you have a beneficial action. You can deem them with long-term action, and the best is these are orally available. So all three are very good products to be given. But in summary, I would say that from whatever research I looked into it, I did not find very strong evidence that you should wait for the actual treatment of osteoporosis. Though there was a couple of papers which might suggested that we wait. But when you wait and just treat, these people are immobile. They actually start losing bones even more. So it doesn't make sense to wait for an operation. It's better to treat osteopenia simultaneously along with going ahead and doing your operation, though you may have to do a slightly different operation. Let's say you were doing a standard TKR. In a normal persons, you might have to put on a stem. You might have to replace some bone grafts, some of the defects, because they're very osteoporotic. So the question here is, do you want to cut your chicken immediately, or do you want to patiently and then do it later? So I think that's what I would like finish. I hope, Ramnik, I've done my stuff in time. And I'll be happy to take questions if anybody has some.
Thank you so much, Dr. Rajput. I think we have time for one question here. So if somebody would like to ask a question. Don't see any.
I think osteoporosis doesn't stimulate anybody.
You probably have elucidated well. We definitely have a good attendance at the moment. I can see 100 participants already. Yeah. So we are at 100 now. So
now they are not allowed to add anyone. Only 100.
So I think. So
how long can we give code? And somebody is asking there.
Yeah, I think there's a question in chat box. How long can you give? So I think the initial period which the company recommends is 3 months, and then you can probably wait and give it again later. So it's a bit expensive at the moment, and I think it also pinches your pocket after a certain period of time.
Okay, I think no more questions. Then we move on forward, and I asked Dr. Dhanashekhar to start presenting share his screen, and we want, once we know the medical management, whether knee first, medical management first. Now we have another one which is bariatric first. If you get an obese patient, would you recommend to do a bariatric surgery first, or would you like to do your knee first? We have Dr. Dhanashekhar here with his presentation. Over to you, Dhana.
Okay, can you see my screen?
Yes, very much visible.
Yeah, full screen you need to make it.
Yeah, 1 second.
On the right top, yes, play. No.
Play.
The fourth icon on your right, on the top. After, yes.
I'm not able to access that. I will try something else.
Slideshow.
Sorry, 1 second.
There are a couple of other questions you can take it.
We have another question which just said that what should be the ideal time to give zoledronic acid?
So I think we've now relied a bit less for zoledronic acid, unless you are doing some other pathology, not really osteoporosis. So I think for really osteoporosis, we've literally gone away from zoledronic acid as such now.
Rakesh, I think the recent treatment, what they are telling you, start with.
I can't hear you.
That is the most,
Sorry, I got cut off, so I couldn't hear you.
teriparatide daily 20 microgram subcutaneously, and 6 monthly you give denosumab. You stop teriparatide after 1.5 2 years, whatever, and continue with the 6 monthly denosumab injection.
Absolutely, that's I think the go-to regime now. The only trouble is that you can only give for 2 or maximum 2.5 years in a lifespan for teriparatide. So it's better to give 1 year and then keep it for a future 1 year more.
Probably again, because I'll say is that the problem with denosumab is that the moment you stop, you increase the chances of vertebral fractures. So you have to keep that in mind. So Once you start your denosumab, then you have to be very careful because of vertebral fractures once you stop denosumab.
Right.
Yeah, I think probably we have his presentation, Dr. Dhanashekhar now. Yes.
Thank you, Ramnik. Thank you, President and Secretary, for the invitation. So I'm going to talk about whether we want to do a bariatric surgery first or a TKR first. So we look at the statistics from India. This is from the National Family Health Survey Statistics 2019 to 21. The incidence of abdominal obesity is really high. More than 40% of the female and 12% of the male are abdominally obese. That's a central obesity. That's a problematic area. It is defined as waist circumference more than 80 centimeter in women or more than 94 centimeter in men. That's equivalent to around 38 inches. So we can see the dark orange areas where the abdominal obesity is very high. So we will be facing patients with gross obesity. And what happens if you do a TKR in them? There are a lot of issues like cardiopulmonary problems, prolonged ICU stay, increased risk of DVT, infection, and revision rate. So these are the meta-analysis showing there is a odds ratio of 2.38 increase in chance of deep infection and 1.3 odds ratio increase for revisions. 30-day post-operative complications are higher. Odds ratio is 1.47. There is prolonged hospitalization, higher cost in you undergo TKR in these obese patients. So there is increased operative time, which is again leading to increased infection rate and increased risk of DVT. Again, another paper showing that the national registry of more than 15,000 patients has shown that increased risk of reoperation and complications. So now we look at obesity surgery. The obesity surgery has gone through a lot of developments. The multiple options like sleeve gastrectomy, Roux-en-Y gastric bypass, or adjustable gastric band. The boy on the right is the heaviest boy in Indonesia. He was weighing more than 168 kg at 9 years of age. So he has to undergo the gastric bypass surgery and he lost weight and is back to normal routine. So gastric bypass surgery is doing wonders, and we want to know whether we can apply it for our patients undergoing TKR. So whether you want to do a TKR first and send them for gastric bypass surgery, or you want to do a gastric bypass first. So basically, obesity, we can classify BMI based on BMI. More than 40 is morbid obesity. More than 50 is super obesity. So if you have somebody with more than 50, we really should consider bariatric surgery. We need to know what type of bariatric surgery they're undergoing. Gastroplasty is only like sleeve gastrectomy. It's only restricts the intake. So there will be some deficiency of iron, vitamin B12 and protein. But gastric bypass leads to bypass of the jejunum, duodenum, and leads to malabsorption. So they have also have wound healing and osteoporosis. You should know what type of gastric bypass patient has undergone. So what does the literature say regarding bariatric surgery before TKR? So the outcome after bariatric TKR, after bariatric surgery, these studies show that there is high risk of complication in these patients, higher risk of revision due to infection and instability. So this is from Mayo Clinic, Rochester. They compared BMI less than 40 and more than 40. Patients are having higher incidence of infection and instability. This is a meta-analysis. Does bariatric surgery really benefit patients before total knee arthroplasty? They also they conclude there is higher risk of blood transfusion and increased risk of complication during the follow. This is again one more paper which in the Journal of Arthroplasty, which says that the experience with TKR after bariatric surgery is not great, and there is slightly increased complication. So these are all older literature. We need to look into newer literature. This is again from JBJS, similar conclusion from 2016. These papers are either level 4 or level 3 with poor evidence. There's a newer literature coming up. It's a recent publication from JAMA 2022. This is a randomized controlled trial. Patients are undergoing randomized into two groups. 82 patients were randomized into two groups. One group underwent bariatric surgery first, then TKR. The second group underwent straight away TKR. So the conclusion was the weight loss following bariatric surgery led to less complication, especially when the BMI is greater than or equal to 35. So some of the patients who underwent bariatric surgery, around 12 patients in the 41 group, they deferred surgery, TKR. They become asymptomatic. So if you do a bariatric surgery before TKR, some of the patients are becoming asymptomatic and they can avoid TKR also. So this is the newer evidence and level 1 evidence and this has been republished by Journal of JBJS in 2023 May edition. They have republished this article, JAMA article, and they concluded that definitely bariatric surgery should be offered to patients before undergoing TKR. So when do you do it? Timing of the surgery. This paper says there is no major difference between whether you do a sleeve gastrectomy or a jejunal bypass, and timing, at least we need to wait for 6 months. 6 months to 1 year is the time after bariatric surgery that the patient should undergo TKR. So again, one more article, which newer publication, which says there is no major difference. Risk of major complications are not very high, whether you do it first or second. So obesity is not a big major issue, and we can address it with either bariatric surgery before TKR. If they have a super obesity, they have associated cardiopulmonary problems, we can offer them bariatric surgery. If they're not that so risky, they are still ambulant and they don't have major cardiorespiratory problem, we can directly offer them a TKR. So the choice is open. Both the options are good. If the patients have cardiopulmonary risk, we can offer them bariatric surgery before. Probably if they don't have multiple risk factors, we can directly offer them a TKR. Thank you very much.
Thank you so much, Dr. Dhanashekhar. I think this is open for questions if someone wants to share in the chat box.
What is the cutoff value for TKR of BMI?
So generally, we try to get a consensus, but there are no at present. There are no consensus. They say 40 is the cutoff, but we are done selectively for fit and active patients, even up to 50 or 55. So it is more of individual patient-based choice. There is no clear cutoff. There is no consensus on exact cutoff of the BMI. So if there are coexisting cardiopulmonary problems, other anemia, all these other problems, osteoporosis, it's better to do the gastric bariatric surgery first, reduce the BMI, wait for 1 year, then offer them a TKR. If they are active, walking, and healthy, we can offer them the TKR straight away.
Dr. Rajput has raised his hand. Dr.
Yeah, Dhanashekhar,
Yes.
what we have noticed with this very fat, and I work with a lot of Marwadi patients. So some of them have got, though not very high BMI, but their thighs are very big. And some of them may have a very high BMI, but thighs are very small. Do you, in your practically, when you do operation, you look at that aspect also, or you just look at the overall BMI on these patients?
So I reviewed a paper for Journal of Orthoplasty, which was published last year. They had two protocols, two units following two protocols. One unit following this method of when the thigh circumference low, they straight away operate, even if the patient is very obese. Other unit following the criteria, even if the thigh circumference is thin and patient is obese, they claim it is a high risk. So what the outcome was, if you have a higher thigh circumference, the duration of surgery is prolonged, but the actual central obesity is the problem. That only increase the risk of infection, cardiopulmonary risk, postoperative hypoxia, ICU stay, all these increased blood transfusion, all these are influenced by the central obesity. So thigh circumference does not influence your outcome. Though technically it's difficult intraoperatively to do a patient with a big thigh circumference for the surgeon, but outcome-wise, outcome is decided by the obesity, the central obesity, the fat, inflammogenic effect of the fat, the stress on the heart and the lung, all these factors, number of blood transfusion, all these factors influence not only the thigh circumference.
Just one collateral question to that. Do we actively refer these patients to bariatric? Because what happens is bariatric is not a very easy surgery. Some people can even die from it. Then how much are we liable for? Because we send these patients now for bariatric. So it's a general for medical legal aspects. How do we, or how cleverly should we refer these patients to bariatric?
So the patients has to be referred to a proper bariatric unit, which has a high volume unit. Luckily, we have our local hospital called GEM Hospital, who are well known for bariatric surgery. So they screen the patient. I generally refer everybody, but I tell them only if they are fit and the surgeon gives clearance, you should undergo. Just because I said they should not undergo, they are the authority. They will decide whether you will benefit from bariatric surgery. If they are fit and they are undergoing, they are able to cope up with the surgery. Some patients, they differ. They say they are too high risk for even any bariatric surgery, or they may not benefit from a bariatric surgery. So I've seen both a spectrum, and it's a responsibility of the bariatric surgeon who's offering the surgery, not the orthopedic surgeon.
Okay. I think just one more question I think I'll just ask is, tell me one thing. In your OPD, you're sitting and you have a patient who says, I don't want bariatric. I cannot move. And you also see practically that even if you send this patient for a bariatric surgery, it's not an overnight miracle. And practically a catabolic state remains for 2 years. So would you keep that patient on bed for 6 months or to 1 year because you've done a bariatric, or you would say, let me do the TKR and then see? The mobility is of better importance here than doing a bariatric.
So the decision is not made by myself alone, our team of anesthetists and cardiologists and pulmonologists. So this is the team who evaluates the patient. So we refer them to the cardiologist, pulmonologist, and anesthetist. Everybody gives a high risk and go ahead. They give the green signal, we go ahead. We explain the high risk and go ahead with the surgery. If any one of them say it is too high risk to give anesthesia and operate now, then we defer. There's no other option. There's some point we have to say that we cannot do it.
Okay. I think we'll move forward in paucity of time, and we'll have Dr. Arun Kannan to tell us on preoperative workup in a very obese patient.
Yeah, good evening, sir. You can see my slides, sir.
Yes, Arun, we can see
Yeah,
your slides.
So continuing on what Dr. Dhanashekhar sir has been talking about pre-op workup in morbidly obese patients. Not everybody, I mean, obese is the same. So we know the BMI cutoffs, but the drastic difference is class 3 obesity. There have been multiple studies that have been done on TKR in class 1 obesity, 30 to 35, 35 to 40. Not much difference in complications as compared to normal people in class 1 and class 2 obesity. Class 3 or morbid obesity with BMI more than 40 is the red flag that has been shown to have higher complication risk established across multiple studies. Overall 1.6 times higher complication rates in this particular morbidly obese group, and that is what we will be concentrating on. And as we've been seeing, it is not just thigh circumference and increased mass. It is an overall state of unwellness. They are all overall unwell. They have multiple comorbid conditions, diabetes, dyslipidemia, hypertension, and even malnutrition. It is a pro-inflammatory state. Therefore, two complications that we are particularly worried about is one is infection and the second is mechanical failure, loosening in the short or mid-term. So what do we do in the preoperative stage that we can avoid these problems? As far as deep infection goes, in the morbidly obese group, the risk of infection is 6 times higher. If you clump together class 1, class 2, this will become slightly lower. But if you are looking at really morbidly obese patients with BMI over 40, then the risk of infection goes up significantly higher. So why? As it was pointed out, it's a prolonged operative time, overall state of unwellness with a weakened immune response system, poor vascularization of the fatty tissue. But these are all generally not very not modifiable unless they drastically reduce their weight through a bariatric surgery. What we can do apart from bariatric surgery to optimize these patients for surgery is control their diabetes, control their malnutrition, and appropriately dose them for antibiotics. If you have, as I said, the infection rate was highest when morbidly obese with diabetic is taken as a factor together. Therefore, in these patients, the infection rate goes up to 10%, which is twice as high as a morbidly obese individual without diabetes. Therefore, HbA1c optimization is absolutely essential before surgery. At least in this age group, we must target for a HbA1c less than 8. So we have to optimize them before surgery so that hyperglycemia is controlled. Secondly, we all know that low albumin levels is an indicator of malnutrition, and it is a significant risk factor for infection after TKR. The surprising thing is that obesity and morbid obesity are associated with the higher risk of hypoalbuminemia. So they are obese, but they are at the same time malnourished. So for these patients, we must look at serum albumin levels, keep them above 3.5. If it is less than that, we have to optimize them before surgery. Simple measure to optimize is oral protein supplements, 1 gram per kg per day for about 10 to 14 days. So next thing, it is extremely rampant to underdose these morbidly obese patients. There was this interesting study which found that 95% of patients over the weight of 120 kgs were underdosed for their antibiotic. And this led to higher rate of prosthetic joint infections. Normally, most of us use cefuroxime, which is the second generation cephalosporin, normal less than 75 kg, 1.5 grams. If the weight is 75 to 100, increase the dose to 2 grams. If it is 100 to 125, increase to 2.5 grams. A simple chart. Just we have to take cognizance of the weight and dose the antibiotic appropriately. Second thing we are worried about is aseptic revisions, 1.5 times higher risk of aseptic revision in this category, most of them from tibial component varus collapse. There was this nice article that spoke about small tibial sizes leading on to varus collapse in morbidly obese patients. And this is because the proximal tibial bone stress is directly proportional to body weight and indirectly proportional to the tibial size. Smaller tibial components create a much higher stress on the proximal tibial cancellous bone, leading on to varus collapse of the tibia. So it is important in these patients to preoperatively template wherever possible for tibial size. You can use CT-based planning with navigation or robotic platforms, or use radiological markers and estimate the bone size. And if the tibial plate size is in the lower 50% of the manufacturer's availability, let's say size 1 to 6, and you have size 2 or 3, keep stems available. So this was a patient, 1 or 2 kgs, tibial size 2. So we had added a tibial stem. Again, malalignment is with high BMI is a deadly combination. 18 times higher risk of revision in this particular category if you have malalignment. So this was an article published by one of our authors from Chennai, Raj Khanna, where he used navigation assistance and showed that he had good outcomes with navigated total knee in morbidly obese patients. So in conclusion, BMI less than 40 is not much of a worry. The red flag is morbid obesity with BMI more than 40. For infection control, need HbA1c less than 8. Serum albumin level to be corrected, record weight and dose antibiotics appropriately to prevent mechanical complications. Preoperatively template for the tibial size, keep stems available, especially if you are having a tibial small size, and use technology assistance wherever possible to avoid malalignment. Thank you.
Thank you so much. Thank you so much, Arun. That was a very well elucidated talk. So taking it further, can I ask somebody to ask some questions if there are any? Raise your hands.
Yeah, Arun, I have a question.
Yes, sir.
You said that one should wait for the HbA1c to come down below 8. Now, if let's say somebody has 8.5 and they're already like, when these patients come for OT, they just want to get it done basically, and they'll refuse even bariatric. And when you refer to endocrinology, our endocrinologists are actually going to say that it's going to take more than 3 months to get HbA1c down. But I can get you the sugar control very good, and you can go ahead with that. So what should we do then?
Generally, I think we also had this, dilemma. What we've been following is we look at HbA1c. If it is more than 8, it is an indicator that sugar control has not been good for a period of time. But there is nothing to state that you have to control it for 3 months, get the HbA1c down and then operate. But if you have HbA1c more than 8, then control glucose for a period of time, at least 2 weeks, and then take him up for surgery.
Okay, I think that's a good takeaway from that.
So if you're looking at literature and what the literature says on HbA1c and sugar controls, Rakesh, the literature is very clear that if you have HbA1c of less than 7, your risks for infection and complications is much less. However, if the patient badly needs a knee, then you can actually safely go up to levels between 7 and 7.5. So that's what the literature has to say.
Can I add one comment? I had a patient who had uncontrolled diabetes, uncontrolled hypertension, morbidly obese. So he came for a TKR and he was not able to control. So this is the patient I referred again to bariatric surgery. So they benefit from weight loss, diabetes is controlled, hypertension is controlled, and they can come back later for a TKR. If they are very symptomatic, then no other problem, no other go. But if they can postpone TKR, they are the ideal patient for bariatric surgery.
Abhay, but at the same time,
Can I ask one question?
Yes,
know,
yes.
how often you do serum proctosamine, what is mentioned in the literature, which tells you about last 2-3 weeks glycemic control. HbA1c tells you about last couple of months, 3 months or so. Proctosamine tells you about last 2-3 weeks of glycemic control, and your fasting postprandial tells you about last 24 hours control. I think none of us do that.
None of us, sir. At least I have not done so.
Yeah.
Done, sir. And I mean, even for HbA1c, I mean, there are some conflicting reports that whether HbA1c is important or perioperative hyperglycemia is more important. There are definitely studies that state that perioperative hyperglycemia is more important than HbA1c. But I think in this obese population, we have to give credence for HbA1c, do correct and then take them.
Another thing about
I think
another thing about the pre-op workup, these obese patients are malnourished. Their hemoglobin is low. We all think the obese patients are healthy, but one thing is their hemoglobin and albumin level is low. So you always need to look for that malnourishment and low albumin level and osteoporosis. That's also very important.
I think we will just say that why don't we distribute this into two, because the two talks, HbA1c is a separate entity when you're talking of somebody who's a lean and thin patient, and then you look at probably the average blood glucose levels as well, perioperative. Whereas when you're talking about an obese patient with HbA1c uncontrolled diabetes is also poor nutritional status, you probably look at it as a different entity than combining the two as an HbA1c. Both would then definitely be a different entity.
So a very logical differentiation comes from the basic philosophy difference when you're doing an emergency trauma vis-a-vis doing an elective total knee arthroplasty. So when you're doing an elective trauma, we understand that if you have acute sugar control, irrespective of even a higher HbA1c, you've got to go and do the job. Otherwise, the patient's chronic control will also not get done. But when you're doing elective surgery like a total knee arthroplasty, you've got to be looking at a little longer duration control before we go in and do an elective arthroplasty procedure. So that pretty much kind of logically sums up a lot of things.
Yes, I think we'll move forward. So we have Abhay has already shared his slide on stemmed total knee for obesity osteopenia cases. Yes, Abhay.
So thank you, Ramni. Thank you, IA. And very interesting conundrum of important relevant things which Arun has opened up, especially the sizing of the knees in obese patients. So we'll just walk forward. So when you talk obesity, what are we really talking about? So the Australian Joint Registry started collecting data on BMI by 2015, and till date they have data on about 487,000 knees and about 95% of capture for all these knees. And essentially, the patient who is undergoing arthroplasty and total knee arthroplasty is essentially one who's either pre-obese or obese, which is 25 to 35 BMI. So essentially, where problems start to walk in are the 30 plus BMI patients, which you start labeling into different categories of obesity. So the first question that we need to ask ourselves is, do these patients really need a knee? Yes, of course, the demand is higher. The complication rates for a total knee arthroplasty in these patients is much more than the non-obese. Especially septic revisions are higher than the aseptic revisions. And the morbidly obese patients will have lower knee society and functional knee scores. But these are patients which on these systematic reviews have shown that they gain benefit in functional outcome, which actually surpasses the risk for revision and complications. So yes, these patients do need a total knee arthroplasty. Now, the very interesting thing about why are we talking stems in TK for the obese essentially comes from the fact that if you see morphologic data for these very obese patients, the one thing that is standing out is that a lot of these patients morphologically will have knees which fit into the lower percentile of the average sizes provided by the different companies. So if you've got a 1 to 6 size or a 1 to 8 size, a lot of these very obese patients will have small knees, and that is why they would have a more focal loading, a more weight transmission problem across these smaller joints that they have, and thence the several problems that can come up and the several things that we envisage with total knee arthroplasty for the obese. So the question is, where is the issue? So if you look at this whole lot of publications, the Journal of Arthroplasty publication by Abdel in 2015 saying, if you have a BMI more than 35, even with these well-aligned knees, a lot of these patients are susceptible to aseptic tibial failures. In addition, weight gains post-total knee arthroplasty also contributes to accelerated revision for aseptic loosening. Another Journal of Arthroplasty publication in 2017. And Fering and his colleagues have published that catastrophic varus collapse of the tibia in obese is a real entity. The other is by Berend, which says implant migration and failures are related to body mass index and tibial component size. And hence all this discussion about bariatric first or knee arthroplasty first. But here's a very interesting one by Rees et al. In Clinical Orthopedics in 2013, which said that these short-keeled cemented tibial components are the ones that have an increased risk for aseptic loosening. And these are some of the very commonly used modern joints that we have in our armamentarium. So where is it all going wrong? So essentially what is happening is that these smaller knees, big patients, obese patients, especially the two types of obesity, one where the knee is really massive, the second one in which the massive the basic distribution of weight is more on the proximal thigh and proximal body and lesser in the knee. But both these category of patients will have predisposition to aseptic loosening and medial bone collapse, which causes increased stress on the implants, and they have altered kinematics of knee motion. So where do stems come in? Stems essentially come in as we understand that they increase the stiffness of the component, resist bending forces on the tibial component, and reduce strain on the proximal tibia by 40 to 60%. And depending upon whether it's a short stem or a long stem, there are different categories of decreased compressive and shear forces. And the interesting point here is that the long stems essentially improved mechanical stability, but they also come at the cost of proximal stress shielding and stem tip pain, which is where cemented arthroplasty for these patients comes in very handy, and hybrid cementing has a very major role. Notwithstanding the fact, this paper by Ridian Morgan-Jones on revision knees, that stems needs to be actually logically used to get fixation across two zones and not just across one zone. So here's where we try and sum up what is evident. So you have a long-term data on 4,000 patients, BMI is more than 30, 7 had tibial loosening. So there is a non-statistically significant difference between the functional outcome scores between stemmed and non-stemmed group. And the stem TK showed here to have decreased tibial loosening at 2 years. And if you looked at the data for prophylactic fixation, this actually revealed that there was no difference in the follow-up in the functional outcomes between the stemmed and the non-stemmed patients. So coming to what we have as evidence. So this national registry study said that cutting across different types of obesity, class 1, 2, 3, the basic higher rates of revision surprisingly came in the class 2 obese patients, and that too in the stemmed group. And there was no significant difference between the stemmed and the non-stemmed TKs in any other BMI group. So this registry data says that stemming a total knee is not associated with lower rates of infection. And to end, as a take home, there is this fantastic study published in Clinical Orthopedics by Sebastian Perret, which says it's a randomized controlled trial, which says that stemmed total knee have higher functional outcomes for pain and function, but the differences are small and they're not very clinically relevant. But the percentage of patients experiencing complications are not very different in the stemmed and the non-stemmed groups. But stemmed themselves, especially the longer ones, have difficulties, including difficulty in revisions if they need to, proximal stress shielding, which in itself may predispose to secondary fractures. So stemming a total knee as a standalone reason for obesity is not the way to go. One has to have certain other parameters where one would use fixation across two zones in the form of stems to actually stem a total knee replacement in an obese patient. Thank you so much for your time.
I have one question. Like you said, small femurs and available stems in the country and negotiate in the canal is quite difficult. So in those situations, what you suggest? How do you proceed?
So there are short stubby stems and there are revision tibias. So that's one answer. The other thing is that we don't undersize our tibias so as to not get a cortical cover on the tibial side, because that itself will predispose to collapse. So in case you have a size, you can use offset stems. So those are possibly our go-to solutions that we have. And there are other components which have a reasonably good, fairly long size 45, 46 mm keel, which will give a reasonably good fixation for the cemented tibial component.
Dr. Abe,
Only few companies have cemented stem in the femur side is not available in the country. What I feel.
Yeah, so the aseptic loosening is a problem that is more being associated on the tibia side, not so much on the femur side.
there is this issue of stress shielding with your stems, isn't it, Dr. Abe?
Yeah, so the longer stems have a proximal stress shielding. And if a obese patient is already osteopenic and you put in a longer stem more than one needs to, then you're actually increasing the proximal stress shielding, you're actually increasing the loading on the cortex, and you're actually predisposing them to secondary pathological fractures. And that's actually what the national registry data said, that in the class 2 obese patients, the actual problems was more in the stemmed group with the class 2 obese rather than the ones in the non-stem group. So stemming a tibia in an obese patient in a total knee is not the way to go. You have to have a valid reason to stem the total knee in an obese patient if you have to use a stem.
Yeah. Can I ask you a question?
Yeah, please.
So how long is this stem is a real issue. For example, even if you don't interested in putting a stem, some of the primaries have longer stems on the tibial side.
Exactly.
And some of the primaries have shorter stubby. And there is a difficult situation, which one you would like to use, the short ones, the medium ones, or you would like to use the short stubby stems or a long cemented or an uncemented stems. I think, the choice is not clear, I think. And also, if you would like to use a short stem, the primary tibial component, and I think, the choice should be between, a normal, some of the manufacturers have a short keel, whereas some ones have a longer one. Which one you would like to go for?
Yeah, so very, very interesting and a very correct observation, Dr. Narayan. The basic thing is that the primary go-to implant would be a one where you have an adequate length keel. So like the Smith and Nephew Anthem has a very good keel, and like the Zimmer Biomet gives one of the Vanguard knee has a brilliant keel, which will substitute for the stem that you need. But if you're using the Attunes or even the Personas, a short stubby stem is a very good go-to option. And if you really think there are other confounding factors where you need to stem, you could use a cemented stem, but the shortest one that will do the job. Because there is a paper also, a randomized control trial saying that stems with short keels do tend to have earlier and a higher loosening rate on the tibia.
Can
No,
I,
Abhay, there is a paper which also says that probably, and these are the patients wherein you use a short, stubby, but a fully cemented stem, that probably takes away and gives you the benefit of whatever you just mentioned regarding
Yeah, so
the
the basic understanding which has to be very clear with all of us is that once you are stemming in our tibia, we're actually creating proximal stress shielding. We're actually creating more room for micromotion and thereby over a longer term creating the risk for a stress fracture. So the cement augmentation in zone 2 predominantly is a very good additional fixation which will give us good stability and which will also, prevent the problems of, having a medial collapse with not using a stem or using a short key.
Okay, I think we'll move in forward because we're short of time.
Okay.
So going in forward, we have Mrinal. Actually, Mrinal had to travel because of some family emergency. So he shared his presentation with us. I can just take it forward. Let me open this Mrinal's presentation. Can you see Mrinal's presentation now?
No, not yet.
Not yet.
Yes. Yeah, I think this should be visible now.
Good evening, friends. I'm Dr. Mrinal Sharma, and today I'll be talking about total knee arthroplasty in obese patients, where I'll be giving practical tips during surgery and closure. So, what are the surgical challenges we usually see during total knee arthroplasty in obese? The exposure is usually difficult. The fat is pretty stiff in some patients, and it can cause a lot of difficulty in exposing. There's a difficulty in subluxing the tibia because the thigh and the leg calf fat usually approximates and doesn't let you bring the tibia in the front. There can be difficulty in cuts in the proper alignment. You can have problems with component positioning. With the prosthesis choice, you also need to understand that especially stems need to be used in obese patients, and the closure can sometimes be nightmare in such patients. So when you expose, make sure that you are not conservative in your exposure and you do the appropriate length of incision, whatever is required, so that you can have a good visibility across. You need to understand the difference between loose fat versus a stiff fat. Whereas a loose fat would actually, just fall apart and give you a good, nice exposure, and a stiff fat is going to cause you a lot of problems during soft tissue. The 2 kinds of fat which the patient should have around their knee. The other thing is I usually recommend is sometimes if you have obese patient where you don't have more than 30-40 degrees of flexion, I usually recommend a quadricep snip. It makes your life very, very easy, and it's very easy to close, and there's no any dysfunction later on after the surgery has been done during the rehab. Patella can be a problem. Usually it is not recommended to invert the patella in obese patients, so I usually make a pocket into the lateral fat pad where the patella actually slips and sits there, and it's pretty easy then to laterally sublux it and expose the femur. For patients where you're unable to actually flex, hyperflex, and do the Ransal maneuver and bring the tibia in front, it's always recommended that you do distal femoral cut first. So I do always in a lot of these patients. And once you're actually using conventional instrumentation, if you're putting an intramedullary rod, make sure you lavage the canal so that there is minimal chance of embolism from the intramedullary canal. So the lavage reduces that chances. And then you can actually do a distal femoral cut and get access to the proximal tibia easily. I recommend using technology in all my cases, which are very obese. I have done a thesis here in 100 cases with and without navigation in obese patients. And you can see even difficult deformities with the soft tissue titration and the minimal release, you can actually get them to correct under technology. Alignment accuracy is achieved, and actually there is no violation of the intramedullary canal once you use navigation robotics, and that reduces actually the chances of any embolism, which is the most important thing in obese patients, because if you're doing especially one by one knee replacement or bilateral, which I don't recommend in obese, it can cause problems, especially fat embolism, other issues if you're actually violating the intramedullary canal. And technology helps you, but balancing and correction also is better with the navigation or robotics in obese patients, because you are able to actually do a titrated soft tissue release and get the monitor correction and cross-check it. Component rotation usually is, I check all three parameters where I use the right side line, the posterior axis of the femur, as well as the transepicondyle axis, and all these three needs to be taken care so that the femoral component rotation is correct. And also you need to understand that a lot of times in these, the soft tissues actually do not let you place this, sizing jig and the rotation in the proper position. So all the soft tissues needs to be actually, really correct mixed flexion deformity in these cases. So it's a lot of hard work and mobilization by assistant which is required in these cases. You do a trial and you check that the components are sitting well and your patella is tracking well without any lift off, and we can see that in this case it's pretty well tracking well. The tibial component rotation is usually assessed, and I use my own Sharma's Venn diagram method technique where two circles are drawn on the proximal cut surface of the tibia, and the axis of rotation is given by the points joining this intersection of the both circles. And that's very accurately proven on post-op CT scans where it is 96% accurate. For the components, always use the stem tibia in cases of obese patients, because it actually reduces the stress on the tibia, and that is where actually failures occur in the long run after 4 or 5 years. So I use a hybrid fixation where the proximal part is cemented and the distal stem is rooted and fits into the cortical medullary canal, and it's cemented, and that reduces the stress on the tibia, and the failures in the are reduced. The final outcome can be checked on table. You see it's corrected to 1 degree, whereas in 1.5 degree flexion on that reduced. Closure can be a nightmare in these patients. Make sure you have 3-layer closure. The capsule is 100% watertight. And you close all the dead space in the deeper layers, and then septic closure is done. My personal choice is to use staples in these cases, because I've had a few cases where there has been wound adhesions because of the monocryl cutting away, or the derma bond not working properly, and these patients, when they do physiotherapy, the wound can wait and adhesions can occur. So it's very important that a 3-layer. So some examples: 55-year female, BMI 125. Navigation was used, stem tibia was used, and this is just one side done, and 3 months later the second side was done. And this is the same patient, 5-year follow-up, and she's doing perfectly well. You can see she's walking, she's still 125 kg, hasn't lost weight, but she's perfectly well. Another case, 50-year female, BMI 39. You can see how obese she is. Another case, 60-year female, BMI 41, and she's a lax fat, and she's walking well. She's a happy lady, pretty in knees, and she's doing fine. The stems were used on both sides on the left side. So the take-home point should be expose, don't be conservative, do not undermine the margins, subluxate the patella into the lateral fat better. Take a distal femur cut first, that is what I prefer. Use technology wherever possible, stem the tibia, replace the patella, and always do a meticulous watertight layered closure. That's very important. Thank you for patient listening.
So I think that was pretty clear from Mrinal, the take-home message and the points that he wanted to share. Any questions, we can just go ahead. Otherwise, just move forward.
Ramnik, just one question on Mrinal's talk. I think the rest of the points we were all okay, but what about this patellar replacement? Does everybody agree that for a obese patient you should replace patellar?
I probably would. There is a question mark. I don't like, because these obese patients have other issues. Mrinal has pointed out in his talk that he always likes to replace the patella. I'm on the other side of the spectrum. I don't.
Okay.
Narayan is raising his hand.
I would like to, replace patella in most of the patients, but not in these obese. And I had few disasters with that and stopped doing them.
So can I
Dr.
make...
Dr. Dhana, you've raised your hand.
Yeah, that most important thing is wound closure. So the wound has to be closed in multiple layers, and I always use Ethilon non-absorbable sutures for the skin. This monocle usually gives way, and usually there is some subcutaneous collection. So wound closure is very, very important. I personally close all the wounds for a obese patient. I don't let anybody close.
I just have one thing to add, is that these are the only patients wherein I like to put in a drain. They tend to ooze more from the fat. So the obese patients probably are the only patients wherein I would like to put in a drain. Otherwise, I don't use a drain.
But frankly, a drain is fine, but many of these patients will continue to use. They are also malnourished. Their serum albumin needs to be looked at. They usually have low serum albumin, and they will continue to use. In fact, I put them in a brace without, not allow them to flex the knee. You need to give complete rest to the wound so that the wound settles down and then start mobilizing gradually. Do not be in a rush to mobilize these patients, because they can continue to ooze, and it's a serous fluid. There's no inflammation, but it creates quite a concern at that stage.
Mobilization, you mean by knee bending?
Yeah, by knee bending. Yeah, they can walk with the knee straight, but not allow them to knee bend, especially if they're having the serous ooze.
So Hemant, do you anticoagulate them?
Yeah, I anticoagulate them, because it's ultimately, one risk versus another, isn't it? I mean, anticoagulation, I don't think is a concern, unless, of course, they develop hematomas and things like that. That's again another, area altogether.
Well, do you have any trivial injury and fall and periprosthetic fracture?
Yeah. Those things go hand in hand, isn't it? You have to warn them again and again. So last thing you want to have is a fall in these patients. I've had patients with complete transverse, soft tissue are also so, poor quality. I have come with patients are coming with complete transverse quadriceps rupture and patellar tendon and rupture and all that. So
early mobilization without brace or sometimes single brace, then again problem of
yeah. So you need to
buckled and fall down immediately.
Counseling is important in these patients. Yeah, no doubt about that.
I think we will move in forward. Can you see my screen now?
Yes.
Yeah, you can.
Yeah.
So that's my case on totally my nightmare with osteoporosis. Let me share you. This definitely was a very tricky one when it came for the first time. 80-year-old female with a bilateral osteoarthritis knee, standard community ambulator. Every day you see them in their OPD, bilateral 10-degree varus deformity, no FFDs, and a range of movement of 90 degrees. That's the X-ray, long X-rays, and we're focusing here on the left side. So that's what we have here. And this is what was done. Routine, no issues. Patient was not very obese, and everything pointed out to a standard routine surgery. And that is how it was done. And on the third post-operative day, she was sent home as a standard protocol for all patients. On the fifth post-operative day, she had a trivial trauma. She just stumbled while she was walking. She had pain on the left knee, came walking with a brace. A terminal extension was absent. X-ray was done. Then we did a CT because the X-ray looked like this. It was a sunken tibia and the fracture line was extending from medial to lateral all the way involving the tip of the fibula. And that is how the CT looked. Those are the CT images. And that's how you can see the anterior half of the tibia is actually sunk in totally. The posterior side, you can see the tibia is actually lifting off, debonding. And this is what we had. So now the issues were, it's conservative 80-year-old female. Can I leave her like this because she's able to bear full weight? Allow her to extend with effort, put her on a brace because revision surgery has its own share of complications. Trauma people decided why not do an ORE with plating, just plate the medial side, retain the same tibia, pack it with bone grafts that we do and then shift to the first option. And then the next option was you fix and revise or a revision total knee so that you can actually let her ambulate full weight bearing. So considering that we had just operated her, we knew her medical status, we decided to go ahead and proceed. And the problems at hand, we had slope issues, we had joint line issues, we had problems of bone defects, and of course, we all wanted a stable fixation on table. And this is what we noticed when we opened. You can see how much of the gap the anterior tibia had actually gone down, then that the reversal of the slope was there. We knocked the tibia off. It was pretty much very easy to knock it off. The posterior side debonded, the anterior side it had some bone, and that is what just came off. And see, after that we went in, we thought, let us explore the fracture. What do we want to do? We started pushing in, started using all kind of maneuvers just to see what is happening to this fractures. Took in a towel clip, started to see, and actually to understand how much of this fracture is mobile. We wanted to understand that. Even put in an artery forceps and tried to separate out all the fractures till what plane. And we are, of course, at the back end, we also had a C-arm. So this is what we did. We took in our cone reamers and used a cone there to correct our slope and elevate the joint line at the same time. So that's what the trial cone looked like after the reamer. And this is what we did. Trial cone, trial thing, and we realized that we are there. And on the C-arm also we saw the same thing. And we put in a cone, the final cone, and fixed her up. Now this is again, but because we were also looking at a fracture line which was going down and it was actually entering into the zone 2, which was compromised. So we had to go in and put a slightly longer rod and take a hybrid fixation there. And you can see we checked it on the C-arm and now it was very stable. It was just not moving. And that was the immediate post-operative. You can say, and this is a question mark, that you can see the zone 2, the fracture line was actually going down. And this was a post-operative picture. We were able to correct her. 6 weeks post-op, she was mobilized. So she was on a brace and she still continues to be on a brace. But the patient became very comfortable. This is 3 months post-operative picture. This is pretty recent, as of today morning, that we got her to send her this video. There was no extension lag. She is weight bearing, but she still continues to use a walking frame. It's only 3 months that we have fixed her up, and she's pretty happy with what she has now. So my take-home message, this is what we got. A 30-year systemic review of similar cases, and they said in the setting of poor bone stock, loose implants, and certain comorbidities, it is a good idea to do an early revision total knee so that you can get them to prevent further complications and mobilize them early. Thank you so much. It's open for discussion.
Ramnik, you have fully cemented the stem?
No, just the hybrid. The distal part is a very short, thick stem. The proximally is only the cement around the cone. I had to bypass my fracture line, which was extending into the zone 2. So I had to use a longer stem. Otherwise, my preference would always be a short, stubby stem, fully cemented.
Randy, can you do stop screen sharing? Then we can see each other much better.
Yeah, that's what I'm doing there.
Okay, so just I had a very recent bad experience of one of these fractures, which was actually a post-infective case, and I was it didn't fracture like that, but when I was trying to come in the second stage, By the time I took out the trial implants, my whole patellar tendon had now come off. And you were very close to that. I think you had only a very remnant of patellar tendon just sitting out there. Any more, and you would have also. Sorry.
Yeah, I would have. I would have
Yeah,
ended with
if
the
it had.
same. Okay.
So I had to actually reconstruct the whole patellar tendon. I had no natural patellar tendon left anymore. So these can be quite tricky where there is an anterior dehiscence, which is atypical, very unusual. But if you have, then you got to keep this in mind that you may not have any patellar tendon left.
We were ready, so we had our arthroscopy sets and everything prepared, anchors ready. We were prepared to take a graft, and at the same time, let me tell you, I actually had a hinge also at the back. I was prepared to knock off the femur if something goes wrong.
Okay.
Excellent job. Ramnik, femur was fine?
Yeah, femur was absolutely fine.
Okay.
Nothing wrong. It just the tibia, it just sunk in 5 days post-op, and there was no issue. The tibia sizing was pretty good. It was sitting on the cortical rim, and as probably pointed out in the previous talks, it's probably the smaller sizes tibia, and that's what it just gave way.
That's the again problem in this country, that we don't have stem size so many times available, cemented stem mainly.
No, we have. This was Striker system. They already have those stems. The thing is, I actually always like to put a stem wherever I find it's a very severely osteoporotic. Here she did not seem that osteoporotic, and we had a good cortical rim, so we just proceeded forward. And on the 5th post-operative day, we had this nightmare.
Yeah, this has happened to me once. Patient actually, had this happening 1 year post-op, and that was actually the attune. So I had to revise femur and tibia, and put in the long stem. Exactly, I used the cone and built it up. So you have to actually build up the tibia from the metaphysis up. Yeah.
Yes.
It's a great case, Ramnik. It brings home the point that
yes.
you've got to look in at the zone 2 also when you're treating these patients, and you have to be somewhere ready to do a hinge as well as deal with soft tissue problems if they come across, especially
Definitely.
avulsion of the ligamentum petali.
You have to be aware of it and be ready for it. Now, I think probably we move forward with Dr. Dheeraj Maruti Jain on his presentation, morbid obese conditions.
Good evening, everyone. Thanks to Dr. Ramnik and Dr. Ajit and IAA to inviting me as a...
Dheeraj, can you go on your actual slideshow? It still looks like...
Slideshow.
Slideshow with Dr. Ajit.
Yeah, that's better.
Yeah. So again, the obesity is a concern in the country, and it's increasing in last 1 decade, the number of obesity, and it's a disturbing reality in this country. That's a WHO classification of the obesity, and BMI and Quetelet index that predicts the proportion of the fat and hence the outcome of the surgery. And we are orthopedics. We are orthopedician. We are looking for the hip, knee, and ankle arthritis. The negative effect of obesity we all know. Risk of osteoarthritis, according to literature, each 5 kg of weight gain, OA increases by 35%. If patient is established unilateral OA, and if having morbid obesity patients having 50% of the chance they develop opposite knee OA within 2 years. So obesity and knee osteoarthritis, it's interrelated and it's a vicious cycle. In Indian scenario, obesity, they published few of literature by ACE as well as NFHS that ranked India among the top 5. So these patients' challenges, patients factor like multiple comorbid conditions like diabetes, hypertension, cardiopulmonary, and these group of the patients having lack of motivation, lack of enthusiasm, and reduce the immune function. The most common taboos among the surgeon as well as patients, outcome of the TKR in this group of the patients. And when we are talking about the challenges in front of the anesthetist, the preoperative fitness, because maximum patients falls in grade ASA 2 and 3. When we will come into the theater intraoperatively, that's a difficulty in a spinal, intubation, intraoperative, monitoring the BP, SpO2 and ECG. These patients are post-operatively sensitive to the sedatives because of the obstructive sleep apnea, delay in post-operative recovery. For surgeon's point of view, that's again positioning of the patients, application of the tourniquet. Mrinal already discussed about the difficulty in exposure. So here I would like to mention the vital organs like MCL, LCL, and tubal tuberosity avulsion. Post-operative, we are worried about the DVT infection and functional outcome of the patient. So when we see the literature about the morbid obese group of the patients having the problem, the wound healing infection, we already discussed previous speaker, suboptimal alignment, intramodular tibial guide better. So few literature suggests that TKR is safe and effective. Why? Because it lasts for 10 years. When we see the super morbid obese group of the patients, we find that there is a less complication when patient went for the bariatric surgery. But still we compare with the non-obese group of the patient, complication rate is higher. Here the patient's difficulty for the anesthetist is the spinal, and for the surgeon is the application of the tourniquet is the challenge. When we are preparing the patient and positioning, I always suggest that whenever you going for the super morbid or morbid obese group of the patient, you should position yourself and do the preparation surgeon himself. So when you are going to or exposure, always we try to resurface the patella and put into the gutter. We don't want to invert because to avoid the tibial tuberosity avulsion. And it's a mobile window technique for the exposure because exposure is quite difficult. If when we feel the tibial dislocation is difficult, then we go femur first in those conditions. Definitely, MIS instruments here help you us in a difficult situation and you can come out easily. Tibia cut and final preparation, but we check again and again. Definitely nowadays robotics and navigation is available, but if you are going for the conventional instrumentation, you check it double and go for the final cementing. Cementing, if you feel difficulty, go for the two-stage cementing, preferable in those cases. Definitely, if you are complex morbid obese cases, try one more assistant with you. So our observation in morbid obese group of the patient, more comorbidities, ASA grade high, suboptimal alignment, more complications, short-term decreased functional outcome. So recommendation for morbid obese group of the patient should be informed risk-benefit ratio, low pressure tapered tourniquet should be available. Anesthetist plays crucial role. Femur cut first if tibial dislocation is difficulty. Be careful with the MCL, LCL, and patellar tendon.
Notan, can we move forward fast?
I think.
Yes,
Thank you. So I think we covered everything about the challenges during the surgery. Any questions?
I think you can
for
start
helping
sharing
me
your
out.
screen. Yeah, Dr. Narayan. Narayan, you can start.
Can you all hear me or not?
Yes, now we can.
Yeah, and can you see the slides as well?
Yes, we can see your first slide.
Great. So this is a patient with a rheumatoid knee, And in fact, this is a saga of this patient and myself for about a decade. So a decade ago, this patient presented with this kind of knee, which is almost like a windswept type of deformity, rheumatoid arthritis in his 60s. The rheumatoid is poorly controlled. He is diabetic and a smoker. And more than that, he was very reluctant to have the knee replacement for many years. And, obviously for a variety of reasons, including the financial reasons. That was his X-ray. A valgus on the left with a quite severe wear on the lateral side and a varus on the right. That was on 20th of October 2013. And this was the knee replacement, which was done on that day. So it was a just immediate post-op X-ray. This was a quite popular processes at that time, was a Scorpio by the Stryker. So this patient didn't come for follow-up for many years. That was after 5 years, when he came back, this was his X-ray. He says that he was on a bike and had a fall and came with an acute, painful, swollen knee, showing the X-ray which has been presented here in this picture. That was a skyline view and the long X-ray as well. So the financial constraint was also an issue. And after careful thinking and discussion, we thought we will do a tibial revision only if possible. So this was the long stem, distally uncemented, but proximally we had to put cement. You can see that a full block tibial augment is used, as well as an extra, a wedge augment on the medial side. This was the difficult situation because the extra medial augment additionally going on the hemi-block is not possible to attach properly. And we had to use some kind of screw and cement to do this arrangement. So that is 6 weeks post-op. He was holding on. The femur was okay. And that was 22-10-19. You can see the AP and lateral. That is in his second year, the follow-up. The right knee was holding on well. And the left, which is about 7th year, was also holding on reasonably well. That is when the problem started on 15th February 20th. That is in his second year after the first revision of his right knee. He presented with this kind of painful swollen knee without fever, uncontrolled rheumatoid arthritis as well. In between, he had gastroenteritis, probably a methotrexate introduced. And the rheumatologist had stopped him methotrexate, and they shifted him over to something else. And in between, he had biologicals and steroids. I think these are the main issues what you have. Because of these new biologicals and the methotrexate and steroid, all of them probably lead to a lot of these kind of very unpredictable immunosuppression. So infection, you had to do a 2-stage with an articulate spacer. That is 17th February 1920. And I did a spacer, and then you see the corona era started. He didn't come back for about 18 months, maybe because of the corona, or maybe he was not interested in the surgery anymore, and a lot of other health issues as well. Then he came back August 21, that's after corona. And it is the hinge type of cemented knee was done in August 21. He did reasonably well with all those, the gastroenteritis and other things which he suffered in his general health, which was controlled. However, after a couple of years again, he came back with this kind of picture on his other knee, which is obviously loose. This type also, I thought it must be an infection. However, you see the parameters were reasonably okay this time because he had a reasonable arthritis control, the rheumatoid arthritis control, the aspiration was negative, etc. So we had a lot of debate and discussion whether we should do a 2-stage or consider this also as an infection, but it was more looking like an osteoporotic varus collapse type of on the tibial side, and the medial condyle, which is broken through, you can see on the AP view, and we thought it must be an aseptic kind, and we went ahead and revised that with another hinged long stem prosthesis, as the medial collateral is incompetent. So this is about a couple of months after his sixth surgery, and it looks like, you know, we are doing well at this stage, but only the time can tell that how exactly he's going to behave in the future. Thank you.
Thank you, Dr. Hulste. Any questions?
Yeah, Narayan, don't come off the screen. Just go back to your pre-op from the last X-ray.
I did that. I'll have to reshare. I'll share it.
Yeah, I was telling you that don't come off. Anyway,
I
just
thought we
reshare
have,
and
like the previous speaker, you were about to
yeah.
tell me to stop.
No, it's okay. Very interesting X-ray you had. I think we missed that point actually.
I'll get you that. Can you see?
Yeah, yeah. So just, I think it was the fourth or fifth slide from the end.
This one?
No, one before this. One before this. Yeah, this one. So if you, yeah, if you look very carefully on the anterior aspect of the femur, there is a huge shadow.
Yeah,
which is, yeah.
Huge
generally we see this down with a granuloma formation, but you didn't have anything specially when you went in, is it? That's a huge shadow you can see around.
Yes, I mean, we saw a lot of synovitis, which was more looking like a polyware kind of.
Yeah, it's a polyware like shadow. We normally see that
situation, and it was not, you know, not like a rheumatoid synovitis type, and also it was not looking like the, you know, the normal metallosis kind of synovitis which you see. It was more like an polyware synovitis which we had to excise completely. Yeah.
You remember the days when we used to see when the poly was sterilized in air and not inert? We used to see this picture a lot, particularly around the medial aspect of tibia. But here I'm seeing on the suprapatellar pouch. Very typical, very nice picture you have on here.
But it's probably because of the distal femoral wear, which is so much.
Yeah.
Yeah. But yes, within 5 or 6 years, is it really polywear or something else?
Yeah, you know, it used to happen when the poly was sterilized in air. It used to happen at 5-6 years at age. That poly used to break down by 8 years completely.
Yes.
In the interest of time, shall we move on? Can you unshare?
Yeah, we
your
can
screen?
move on. Yeah.
Thank you.
Yes.
Thank you.
Dr. Samir Ali would like to speak on his struggle with obesity and osteoporosis. Dr. Samir.
Yeah, sure. I'll share my screen. Am I audible or my screen is visible?
Yeah.
Yeah, Samir.
So let me thank IAA and Ajit sir for being me here. It's a sort of 64-year-old female without any comorbidities. Her BMI is 37. And this is presented with the first X-ray. So as there is no comorbidities, even though the BMI is 37, we opted for a bilateral single-stage short-term replacement. And it was a computer-navigated one. So this is the immediate postoperative X-ray. On the left side, there was a significant almost 1 centimeter medial defect. So I built up with the screws and cement and hybrid fixation. There is an uncemented stem on the left side. And later, 1.5 years, but probably because the patient had some financial constraints and this medial defect was not too big. And as it's a navigator knee, I was pretty confident about the alignment. So I thought I want to put a stem on the right side. So let's move on. So after 18 months down the line, this is how the patient presented with some pain and feeling of a instability on the right knee. Patient doesn't have any history of fall or anything. So as it is a very short duration, that is 18 months only, I prefer to do a tibial side revision, and same because not much two defects on the medial side also, I just used a long same type of uncemented stems and again build up with the remaining defect with the screws and the cement. And this is how the skyline view, the lateral view, post 1.5 years again. So total 3 years down the line from the first surgery. So what I learned, the obesity and the mechanical failure is very high if the patient is morbid obesity and if the alignment is wrong. So as you see that, you can see almost 22%. If there's some varus malalignment, there's high chance for failure, especially the BMI is more than 40. And most importantly, this is one of the study which shows that the stems help is almost 40 to 60% of the lower stress on the tibial base plate, even if we use a short stubby cemented stems, which is available in the market. So in a tibial stem, we have to consider the stem if there is a significant residual varus, probably because of the thrust, high BMI, tibial defect of more than 10 millimeter, severe osteoporosis, either in intrafractures or high patient level activity, and even very tall patients. If it would have been nowadays, I would prefer to use a short stubby cemented stems, except in case of fractures. So thank you. Just so open for discussions.
You can unshare your screen in the meantime, and Dr. Bhakankar, you can share your screen, and we can have questions in the meantime for Dr. Samir.
I think Samir's case is a very good example of what happens if you don't stem in a defect and osteoporosis combined. I mean, we've been trying to say this all while he's actually shown it with a case.
So what is actually the limit for a BMI limit to stems in all of you? Just want to get an idea. Anyone above the age of BMI more than 35 or 40? What's your cutoff?
I don't think, Samir, just the BMI will be an issue. It's also the quality of bone you're looking at when you've cut off the proximal tibia, and I think both of them should be combined in taking a decision. But what we have learned recently is that any doubt, stem it.
Yeah.
At the same time, if you remember, Abhay has just mentioned very clearly, and before that, Arun also, that also along with BMI, what is more important, what size of tibia that you've been using. If they're smaller tibias, then it's a good idea to go ahead and stem instead, because I can tell you my own personal experience was a 150 kg male patient. My height was 6 feet 2 inches. And I did not use a stemmed tibia because the tibia size was size 6 or 7, which is too big for an Indian male. And I'm talking of an Indian male. So probably I think the way forward is what these two people mentioned before. And going forward, I think Dr. Bhakankar now his nightmare with rheumatoid arthritis.
Yeah, I think some of these rheumatoid patients are extremely challenging, and I think they do present. I think let's see what are the issues here we're looking at. We're looking at these patients where loss of mobility could be bedridden for many months or even years. These patients are severely porotic and are stiff. And especially when these patients have all 4 joints, that is 2 hips and 2 knees involved, that presents a serious situation. In my younger days, I think I used to be a lot more, aggressive in managing those surgically, and I have burned my fingers a couple of times, and I've, I think, learned my lessons as the time has progressed. I think patient counseling is extremely critical in these patients, because you really need to warn them that every potential, every surgery, that is 2 hips and 2 knees, is a potential problem. Any one of the 4 surgeries could go wrong. And unless you do all 4, patient is not going to stand up and walk. So especially when the patient is bedridden, these patients need all 4 joints to be done. The implant choice has to be, you need to have constraints and stems and everything available. Surgical technique is very critical, and in spite of all the care, things can go wrong, as I'll show you. And you obviously need backup options available to you, during surgery. So this patient of mine was a 70-year-old female with rheumatoid arthritis. She was bedridden for 3 years. She was actually the mother of our HR head of our hospital. She had bilateral hip and knee end stage arthritis and near ankylosis of both her knees, and hips were only, she had minimal protrusio, and the hips obviously were ankylosed. So as the protocol is, you do the hips first and then the knees. So I went ahead with sequential hip replacements for her. And I did a hybrid hip for I think the right first and the left. These went off fairly okay. The bones were porotic. And then obviously it was the time to do the knee. So I was, looking at the right knee here. Now, right knee had, I think, just flexion deformity of just about 30 degrees and just only a jog of movement. So it was near ankylosis. And as you can see that the femur and tibia turn into ball and socket kind of situation. There's huge osteophyte, especially at the back here. And this tibia is not going to be mobilized very easily. You knew that beforehand. You can see severe porosis as well. So I was aware that this is going to take a lot of time and a lot of mobilization on the tibia before I can even mobilize and even flex the knee. Patella obviously has some patella baja, and so exposure issues are going to be there. So I started this surgery, keeping backup, as a LCCK as an option, because I was going to need stems on both femur and tibia, and I was using Zimmer's, so LCCK was available as a standby there. As I started exposing the knee, I started dissecting the tibia on the medial side, and without dissecting the tibia on the medial side, you cannot really mobilize the knee and you cannot flex the knee. So that is critical, and it is a very slow and tedious and painful process. And I thought that I had actually mobilized the tibia sufficiently for it to be slightly sublux forward so that I can, then start working. I managed to do the distal femoral cut and then started to flex the tibia slightly more. And then I heard the crunching noise. And the crunching noise was this. The femoral, medial femoral condyle had fractured across, and this is obviously what had happened. So I said, fine, we anyway are going to use a constrained knee. I'm going to, use stems on both sides. So we will go straight away because unless you reduce the tension on the medial side and unless dissect the tibia more, you will not, reduce the tension on the MCL. And this basically fragment has come off because of the tension with the MCL. So I then mobilized the tibia, then finished my tibial cut, and again started to flex the knee slightly more. And I heard another crunching noise. And even the lateral condyle has fractured. Now I said, wow, I got two condyles that are fractured on me here. And I had done my tibia. But then I said, okay, let's again stick with the plan. So I stabilized these fractures with KYS and prepared the knee for LCCK and cemented the femoral side fully, and the tibia was again hybrid cementing, and that was the post-operative X-ray. And the post-operative X-ray, especially in the lateral view, looks so innocuous that this is just condyle. The fracture was somewhere here. And it is just doesn't tell you any idea of what had gone on during surgery. So this is the post-operative X-ray. I think then I think another 10 days, a week later, I think I went ahead and did the opposite knee again. Did the LCCK there. Did not have any fracture on that side, and then mobilized the knee slowly, gradually with the brace on initially, then without brace, and patient was sent home. I had uneventful post-operative recovery. Patient came for a follow-up about 3 years later, and this is the 3-year follow-up of the same patient. Patient was again home ambulation only. Obviously, her rheumatoid condition did not allow her to mobilize great. But yes, she was mobile, and in the end, all worked out well. So important, I think the point here is that you need to have constrained options and backup options available to you when you're undertaking such cases. And things can really happen. I think, as the Americans say, shit happens. Thank you.
Before we move forward for any questions, I'd say you're still young, so you can take back that statement which you started off.
All right, thank you, Ramnik.
Let me ask you one thing. Why did you not think of putting in screws or something also? You had some along with that LCCK.
After I had completed my cuts and prepared it for LCCK, I realized, see, I had to actually release the MCL completely. And there was, after I released the MCL completely, there was not much tension on that fragment, and it could easily fit on in the, you could have put in screws as well. But in the end, it was all going to be fitting under that femoral component.
So
But
you
don't you think
started
that
post-operatively full weight bearing?
No, obviously, yeah, full weight bearing was allowed because I had cemented, got two stems on each side. So weight bearing was not an issue, but I was worried. But so I put a long knee brace on and allowed the patient to weight bear. I obviously didn't want the patient to fall down again or
I have 2
buckle.
points here. So Dr. Hemant, 2 points.
Yeah. Yes,
One,
please.
are you not worried that these loose pieces with that cement and stem going in would end up with osteolysis underneath your component?
There is no,
And you just have
there's not going to be any
have a hinge,
movement there because that fragment doesn't have ligament pulling on it. The MCL was completely released on the medial side on the tibia. So the medial side was sufficiently mobilized. And after the posterior condylar cuts are done, my component was fitting on the, see where is the stress transfer taking place? Stress transfer is taking place in the in the diaphyseal area here on the femoral side because it is fully cemented stem.
That was my second point to you. Now
Yeah.
you have femur on top, you have a tibial stem below,
Yeah.
a femoral, total knee femur stem going. So you have a stress riser in between the two in a very severe stovepipe kind of a femur.
Do you have any other better options?
No, I'm just saying.
Yeah, that's a risk. A patient counseling again. I warned the patient, do not fall down. You can fracture between the two components, between the femur and mid shaft fracture is a big worry here.
So maybe just an idea, because I have a case wherein actually I put in a plate just for this particular reason.
You mean prophylactic plate?
Prophylactic plating.
Yes, but that could be an overkill. But anyway, yeah, you can argue on that.
Okay. Any questions or we move forward? So this is the last talk
No,
for the day.
just Hemant, were you ready with LCCK from the beginning or?
No, from the beginning, I expected LCCK. See, such patients who are near ankylosis, I always keep LCCK available. Because, near ankylosed knees after mobilization with severe porosis invariably need stems on both sides. And it's best to have LCCK as well.
Okay, we'll move forward because the convener has got other commitments.
All right.
I have a flight to catch. Yeah.
Yeah, Dr. Kalai.
So good evening, everyone. So hope the screen is visible. So hereby just sharing some of the common acute skin problems following TKR in rheumatoid and obese patients. So this is the wound status which everyone wants to like to look at, completely dry and everything. But most of the patients, especially the inflammatory arthritis patients and obese patients and someone who is on blood thinner, this is the scenario which we land up in, especially the lower incision part. Then in such cases, we mostly use to splint and give prophylactic antibiotics and go slow with the mobilization. This is one such rheumatoid arthritis patient, diabetes mellitus. She came for staggered bilateral TKR. At the end of almost 3 weeks, she sent us a picture of her right knee showing this kind of wound. We called her, we did an ultrasound, and we did a dire wash. So the skin presentation, especially the lower half of the wound, is always very meticulously closure is needed, and wound care for a long term is also needed. Such another one rheumatoid inflammatory arthritis patient, but luckily she was not diabetic, hypertension, little bit mild obesity. We used a TKR with a tibial stem, but she came with a pouring pus at the end of 3 months. But our HRI-PJ score was normal, so we just went on with a dire wash with the stimulants, and for a 5-year follow-up period, there is no recurrence of any infection with a good range of movement. Another one patient with a truncal obesity, known diabetic, revision and smoker. And this patient landed up with, again, mild wound dehiscence at the end of the incision where we used a VAC and the healing was better. Another one patient, known diabetic, truncal obesity. Here, previous scar incision, a floating knee with arthritis. And we used a PICO dressing. And with consistent 2-3 weeks of wound care and diabetic control, the wound healing was good. This is one patient with known inflammatory arthritis and was on double blood thinner. The day of discharge, there was a oozing of the blood, as Dhanashekhar had said. And this kind of wound closure needs ethylene. It's better than the monocryl. But here, to our surprise, we thought it will heal, but it didn't heal up. And eventually, we tried a VAC and consistent dressing for a period of 3 weeks. The healing was better with a good range of movement. So this is one of the article which shows a similar kind of picture where they did a plastic surgery procedure and the wound healing was done. Coming to our patient, this patient already had 3 joints done, known rheumatoid, and we generally used to get the CRP to know about the implant nature of infection when other implants are there, and also the status of a rheumatoid during the time of admission. She was known osteopenia, and she was on vitamin D and treatment for osteoporosis, and she was admitted for the fourth joint. Everything went fine, but on the second day, when we opened the dressing, this was a blister with the surgical site, especially in the lower off, and to our surprise, the skin in the lower off where we were holding it was like started peeling off. The day one it was very mild. Generally, we used to do a double compression for the whole lower limb on the day one, and the day two morning when we opened, the skin was peeled and the subcutaneous adhesions were there, but it was not deep penetrating. We called our plastic surgery. The plastic surgery, to a surprise, where they were like scared to do any procedure. Initially, they gave that we will do a continuous dressing, debridement, and then closure. But for this particular rheumatological condition, where the rheumatologist advised if you keep on giving some more incision, the wound is not going to heal. So here we thought we have to wait for a while till the edema settles down. The mobilization was restricted. Only the bedside exercise was done, and the continuous dressing was done. The patient was given in a splint with also the foot ankle at 90-degree rest, and the wound was getting bad and bad, and we were waiting for the demarcation to happen. We thought VAC will work, but VAC was not useful, and it was more aggressive, and we planned to do continuous dressing to tackle this kind of a situation as per the advice of rheumatologist as well as the plastic surgery. And we were scared about the implant because this time it was osteoporotic. We used a tibial stem, and we were worried to again take up for any surgery. Our CRP was at the same level, except for the mild rise, which also happens during the first thing. And to a surprise, this patient went home, and for 3 months we did a continuous dressing with water and saline and betadine pain for the periphery, sometimes alcohol, and we made sure our albumin globulin ratio was right, and she was on constant vitamin C treatment and weekly vitamin D treatment, and IV antibiotic we gave for the first month injection targocid, almost a OD, and followed with the ciprofloxacin, because the culture what we sent had no growth, but due to the fear of the implant infection and the wound care, we wanted to give the antibiotic. On the following after 2 months, we stopped all the antibiotic, and she was only on dressing, and this is a 3-year follow period. There was no remission of any infection or any implant loosening. This was one interesting case which we had with the rheumatoid patient. Thanks.
So that was an interesting bunch of cases with the skin complications. And definitely that is one issue that you always experience in these patients, that they are on so many drugs, and definitely rheumatoid patients do have skin issues. You can stop sharing your screen, shall I?
I think
Yes,
he
sir,
has
done,
already
sir.
stopped. Yeah. Any quick questions before we allow Dr. Mahajan to bid goodbye?
Okay. I think we don't have anyone. And there are no questions on the chat box. I think no.
Okay. So any other points of discussion amongst the group here? So I think if there's no other questions or no further discussion, on behalf of the Indian Arthroplasty Association and on my own behalf, I'm extremely grateful to Dr. Ramnik Mahajan for taking up the responsibility of organizing this, I think, a very well attended meeting. And I'm also extremely thankful to all the faculty members. And we are somewhere close to 1,000 members now. And I'm putting this out for more of our fraternity to join the Indian Arthroplasty Association. And with that request, I also thank I think we just have had a support here from the Universal Micronutrients Company. They are one of the first to get into the collagen peptide management in osteoporosis, or maybe to put it the other way, management of osteoporosis by collagen peptide supplements. So we need to see how this evolves over the years. And I express my gratitude on behalf of the association to Universal Micronutrients. Probably they have disseminated the information, and that's why we had about more than 100 people logging in right away. So with that, I thank everybody and wish everybody a very good night. Thank you all.
Thank you. Good night.
Thank you, sir.
Morning now.
Thank you.
Good night.
Thank
Thank you, sir.